Okay, welcome to our special ITP and COVID-19 webinar, which will see our panel of ITP experts answering your questions live. This event is brought to you by the ITP Support Association here in the United Kingdom. My name is Mervyn Morgan, the CEO of the ITP Support Association. At the association, we pride ourselves in providing trusted resources and support for those with the condition. Today's webinar is another excellent example of the support we and other members of the Global ITP Alliance are providing during this international emergency. The Global ITP Alliance, which can be found at globalitp.org, came about following a meeting many years ago in Copenhagen between Mr. Derek Elston from the ITP Support Association's trustees and Caroline Cruz, the CEO of the Platelet Disorder Support Association in the United States. Global ITP, we're proud to say, has now grown to include over 30 member countries. To quote my friend Caroline Cruz, who's also my opposite number at the PDSA in the USA, remember, you are not alone, we are all in this together. This webinar would not have been possible without the support of our event sponsors, Incipia Biopharma, UCB Pharma, and our media partner, UF Creative Agency, along with the members of our expert medical panel and those behind the scenes at the ITP Support Association around the country who support with fundraising and organising our local group meetings. And when I speak about our local group meetings, which in normal times would be face-to-face and in person, even these have now had to move to the virtual world of the internet. Webinars such as this are providing a much needed resource for information during these worrying times. This has been proven by the sheer number of people from all four corners of the globe who have signed up to watch this webinar and submitted questions. Plus, we will have many, many more watching this on Facebook Live. There will be some of you who cannot stay for the whole webinar, but please rest assured we will also be posting a recording of this event on our website at itpsupport.org.uk. In addition, we will also be publishing the key extracts of today's event in the Platelet, our quarterly journal for members. Before we start, I would also like to say a big thank you to the chair of the association's trustees, Professor Adrian Newland, CBE, who has worked tirelessly putting together the panel of experts who will be answering your questions this afternoon. Questions that you have submitted in advance by email and Facebook. In addition, many of you will be asking questions during the event and we will try and answer as many as possible. Professor Newland will be moderating the panel as we go along. And I would now like to hand over to Professor Newland, who will introduce our panelists. Professor.
Hi, thank you, Mervyn. Thank you for that introduction. And of course, just to reiterate the point that of course this will be available on Facebook as well. And so for those who can't stay for it all or want to go over points again, we've had lots of excellent questions that have come in over the last couple of days. And we've really been, I think, wouldn't be surprised by the interest, because clearly there's a lot of interest in COVID virus and ITP. And so we're pleased to put this together, and we'll deal with a lot of the themes that have come through the questions. We've had one or two questions that really go into personal clinical details, which we probably won't be able to answer in detail, although we'll answer the themes that are the background of the question. I would say that if we haven't answered your specific question, I doubt we'll be able to get through them all. If you're a member of the association, then just drop Mervyn an email, and we will answer your question and come back to you on a more personal level rather than here. So what we'll be doing today is just answering sort of the general points that have come up. And we'll clearly do as much as we can, and obviously as questions come up while we're going ahead, we'll interdigitate those if we can do. But there are a lot of points that have come up, in particular the risks to patients with ITP who from the virus, the issues of whether a low platelet count makes you more at risk. There's a lot of questions about splenectomy that are all very similar, and some of these I think reflect the confusion in advice that seems to be coming out, not necessarily from the official sites, but some of the less official advice that's coming through some healthcare professionals, but other bodies that aren't necessarily on top or understand the issues. And I think in an ideal world, certainly in the UK, your GP would contact you and tell you what to do. But in all honesty, your GPs will be completely overladen with work at the moment. And so one of the things that we do with the association, we're putting up-to-date information on our website. The British Society for Haematology is doing the same, and Quinton's been coordinating some of that, and Sue has recently, or as of today, has finished a document that we hope will go onto the website shortly and will be available on advice. And I'll get her to talk about that in a minute. We'll talk about some of the issues of risks of current treatment in ITP. There are a number of questions on employment issues, particularly for healthcare professionals, and I'd like us to deal with those as well. So there's a wide range of things that we're going to talk about. So on the panel today, we've got Drew Provin, who many will know. Drew led on the recent guidelines. Indeed, he's led on the 3 iterations of guidelines that have come up since 2003 on the treatment of ITP, the latest published in November last year. Sue is a consultant haematologist that has a particular interest in pregnancy. Her surname is pronounced Pavord, she tells me. I'm pleased to have got that right for once. She looks after adults with ITP and has a particular interest and is well known for her interests there. Quinton from Leeds, although he started off with a picture of his wife on the screen, is indeed here in person. Now, he's also an adult haematologist from Leeds and chairs the ITP Clinical Forum in the UK. And then we have last but by no means least Rhonda, who is a senior mentor for the ITP Association. She is also a patient who has ITP and had a splenectomy some years ago, and I think her insights into risks, coping with isolation and distancing will be really important to us, and I'd certainly ask Rhonda to chip in whenever she feels there's something she wants to add to it, but I'll certainly ask her specific things as well. So we'll get on with the session today. It'll last for an hour. We'll be finishing at about 5. I don't want to test everyone's patience too much. So as I said, we probably won't be able to deal with everything, but we'll do it as best we can. So I'd like to kick off now by just going to Drew. With the new guidelines that came out in November, and of course the first patient, as far as we're aware, with the COVID-19 virus was only picked up in the first week of December, so we just proceeded that. The guidelines were an update from those in 2010, and I wonder perhaps if Drew could talk about some of the sort of main points about the treatment guidelines, the changes from previous, and any implications for that.
Okay, thank you, Adrian, and thank you everyone else for joining the webinar. This is a 10-year update from the previous guidelines, as you have said, and over this last decade, we've changed our management approach quite substantially, and we wanted the new consensus to reflect the way that we work now, which is very much in partnership with patients rather than being dictatorial in a way. We've become, the patient is really key to the decision making. So it's a joint discussion, which we did say originally in 2010, but even more so, I think, now. And we've moved away, as you also allude to, the move away from previous therapies, which were not great, immunosuppression, etc., with average and indifferent kind of results. We've moved away from these kind of treatments towards more physiological and tried and tested through RC randomized trials, like the CPR receptor agonist, of course. And we had some thrombopoietin receptor agonist data in the old guidelines in 2010, but we've had masses more to assimilate in this latest version. So the data are completely up to date in terms of the TPA receptor agonists and other new molecules, which are going to really eclipse all the old suppressive therapies, which is very good, obviously, for patients, because the last thing we really want to do is suppress someone's immune system, and we'll discuss more of this in the webinar. So it's patient in the decision making, an emphasis on the newer drugs with up-to-date data across the board, adult, children, pregnancy. We've also set more realistic targets for therapy. We're no longer going for some high platelet count. We're just going for an individualized platelet count based on every single patient's conditions at that time, which is again emphasizing what we brought in originally in 2010. It has to be on a patient by patient basis with full discussion and agreement by the patient, setting realistic goals and timelines. So that's quite a big shift away from the previous guidelines. We have built in a chapter right at the end, or a section right at the end, dealing with quality of life, because for the first time in a guideline, I think we addressed this issue, which we didn't really discuss greatly in the first one in 2010. The ASH team, again, have not really discussed quality of life either. But at the bottom line for patients, the most important thing for them is not the randomized data or the efficacy, it's how they feel, how they're treated, what they can do, their limitations, and again, this will come out in the webinar. So really look at the patient, the quality of life, and we've emphasized this quite strongly, I think, towards the end of the document. So without going into big detail, that's kind of where we are. It's a shift in practice away from the old therapies, which are not great, towards newer therapies, which are much better and improving quality of life, which is the main aim for us as healthcare workers.
Thank you, Drew. Obviously, a lot of the information about COVID is now relatively new and changing almost as we speak. And what we've decided to do in the UK, and Sue has led on this, is produce some guidance, not guidelines. Guidance is just is almost suggestions as to the sort of ways you should approach patients with the COVID virus. I mean, I would say one of the risks, one of the big questions that comes up again, and we'll address in a few minutes, is are ITP patients more at risk for getting COVID virus? I think certainly, as far as I'm aware, as of the PDSA webinar last week, there were no patients in Italy out of the 150,000 people who've been diagnosed with ITP. There are one or two since then, but none in the ICU, none seriously. I think we're aware of probably half a dozen in the UK, in which 5 were in established patients with ITP. So this is by no means a common problem. So a lot of the discussions we're giving here on treatment are based on normal, healthy patients. I say healthy, normal patients with COVID virus, some of whom will have other risk factors. And so a lot of the guidance comes from that. But I wonder perhaps if Sue could just summarize some of the thinking behind the guidance that she's pulled together for us.
Okay, thanks very much, Adrian. Yeah, so this was really finalised today, and it's been a collaborative effort between many of the great and the good in ITP across the UK. And we've aimed to provide guidance to really support clinicians who are managing adult patients with ITP, because there are very many dilemmas during the COVID-19 pandemic. And some of those have already been alluded to, but for example, we don't want to make people more immunosuppressed if we don't have to, and potentially increase susceptibility to developing the COVID-19, the coronavirus. And also for patients who have already got COVID-19 and either relapse with their ITP or present as a new ITP during that period, we have to very carefully balance the risks of bleeding from ITP versus thrombosis from COVID, and we don't want to exacerbate that, make that worse with some of the treatments that we need to use for ITP. So as everyone says about these times, they really are unprecedented. And so that's why we've formed a consensus opinion with pulling on all our expertise of ITP, but also ITP and how it's behaved in other viral epidemics and viral conditions, and how we might suspect it might behave with COVID-19. Our experience is building all the time. We are aware of a handful of cases, as Adrian says, of ITP during COVID who've either relapsed or have presented as new patients. The other complicating thing is that patients with severe COVID disease have low platelet, they may develop a low platelet count. It's actually quite unusual, but there are lots of potential causes for a low platelet count, and therefore it's important that clinicians are aware what might be an ITP cause for the low platelets. And so we've provided some guidance on how that might be distinguished. Then if I come on to sort of what would happen to you if your ITP relapsed, obviously the first line treatment in the consensus document is steroids, and they are extremely effective. There is potentially some concern that that might increase susceptibility to developing the virus or you know, becoming sort of COVID-19 infected. And therefore we propose that the first line for patients who are COVID negative may actually be using a thrombopoietin receptor agonist. Usually, as you know, this is second line or third line treatment, and using it up front is an off-label use, but maybe the safer option for ITP relapse patients who are not yet COVID positive or not COVID positive. For those who are COVID positive, we may not want to use the thrombopoietin receptor agonists because they could potentially increase the thrombotic potential. And so in more severe COVID disease, we would be more wary of that and might look for other options. So we're gaining experience of the value of steroids in this sort of inflammatory condition that COVID-19 produces, and also intravenous immunoglobulin, which is usually a very effective treatment for ITP. And lastly, I just wanted to say for the majority of patients, they will remain outpatients, they will not be hospitalized with either COVID or ITP, and then emphasizing the importance of the self-isolation procedures. We follow the guidance from the British Society of Rheumatology, who use very similar drugs to ours, regarding who should be shielded. Now, shielded is a little bit more intense than just the normal self-isolation procedures. This means staying at home and receiving deliveries of food and medicines. It means strict avoidance of contact with anyone displaying symptoms of COVID-19 and avoiding gatherings with friends and families, even in your home. So, you know, distancing, if having your own bathroom and things like that, if that is possible, and using remote technology for contact with friends and family. So who should be shielded? Well, the British Society for Rheumatology, with whom we agree, they say those who are on steroids of more than 20 milligrams a day for more than 4 weeks. So it's sort of more long-term use of steroids. Those who are on a small dose of steroids, 5 milligrams or more per day for more than 4 weeks, plus another immunosuppressive agent in the last 12 months, like azathioprine, mycophenolate, cyclosporin, rituximab. And then a combination, patients who are on a combination of 2 immunosuppressive medications within the last 12 months, so maybe rituximab and mycophenolate, for example. And then another one that we've added ourselves is splenectomy plus ongoing immunosuppressive medication. So for those people who have had splenectomy and are have not required additional treatment within the last 12 months, then they don't need to be shielded, but they do need self-isolation procedures as for all individuals, and be very stringent and vigilant with the prophylactic antibiotics. So start taking them again if you haven't been taking them for a while. So I think they're the sort of dilemmas that we've been trying to deal with in this document. The document will go onto the website for the British Society for Haematology, and is aimed at clinicians managing adult patients with ITP. The one that is already there aimed for patients will remain, and that's up to date. And that will be there as well on the BSH website.
Okay, thank you very much, Sue. I think we could maybe just explore the issue of risk categories a little bit more, because certainly a lot of, as I said at the beginning, some patients have had very conflicting advice, and there's also a bit of misunderstanding about what treatments. I mean, we know that the British Society for Rheumatology's advice on steroids depends on whether you're on a small dose or whether you're taking over 20. There are issues relating to when you had rituximab. There are issues of dose of mycophenolate. So, Quentin, do you want to comment a little bit more about risk categories and some of your thoughts about that?
Hi, Adrian. Yeah, and thanks for having me. I'll just do a quick sound check, because am I coming across okay?
Yeah, you're fine.
Yeah, I think that it is difficult to know with the evidence base we have, but I think most clinicians are taking a lead from the British Society of Rheumatology simply because they have very large numbers of patients on immunosuppression and have a sense of degree of risk, so they've attempted to categorize this way. I think that on my discussions with the rheumatology teams, I think there is a little bit of room for discussion about personal risks and individual risks. So I noticed that a number of individuals who've been dialing in have emphasized, well, what about my occupational exposure to COVID? So I think that these are guidelines that the rheumatologists have produced, and I think individual people who may be at high risk of COVID exposure may need to get an individual view from their clinician as to what they should be doing. So I think these are broad categories that we ascribe to, but I think individual people with very specific circumstances may need a bit of support with interpreting those guidance based on their very individual risks. So I think we had one individual who had exposure in intensive care, for example, which would be a high risk occupation. So I think that needs to be brought in and contextualized with the sort of treatments that they're taking. So coming to some of the specifics then, I think splenectomy came up as a particular concern for a lot of individuals. And as Sue highlighted, I think that splenectomy is an isolated intervention with no additional immunosuppression would be considered on the government website as making that individual vulnerable but not extremely high risk. So for most individuals who are well controlled post-splenectomy with ITP, that doesn't mean that they need to have specialist isolation. So splenectomy is a single event, we think, is not requiring shielding. With the immunosuppressants themselves, there's some fairly specific descriptions by the rheumatologist about what is high risk and what isn't. With the other immunosuppressants, I think you can basically cluster them together. So there is a list on their website about what is and isn't, but essentially an immunosuppressant tablet like azathioprine and mycophenolate, or rituximab during the period where the immune system is suppressed, which is typically 6 to 12 months, could all be considered an immunosuppressant. And as described, you try and put these additional risk factors together to come out with advice on whether you should be shielded or not.
Thank you. And what about the issue of the thrombopoetins, either Trombopag or imiplastin? A number of patients have written in who have only on those, have had no immune suppression for some time, haven't had rituximab for quite a considerable period. and we're a little bit worried about that. I mean, clearly from our point of view, the thrombopoietins we know are not immune suppressive, and would see no reason to restrict a patient with either of those agents who's not on anything else and has no other health risk factors. Do you agree with that?
Yeah, lots of nodding heads there. I think there's a consensus that individuals on those treatments aren't at increased risk of COVID-19.
Yes. And there are a number of the ones that came in through relating to splenectomy, which wanted to know about the increased risk. And I think we have to differentiate patients who've had a splenectomy from those who had a splenectomy some while back, or on no other treatment, and are in remission or partial remission, are on their antibiotic prophylaxis, and those who still require immune suppression, and those who obviously are of an age where they hit the risk factors, over 70, either hypertensive or diabetic. And I think it has to be an individual decision, but certainly someone who's just had a splenectomy and is otherwise well doesn't have to worry about that. I was certainly alarmed by the question we had from the lady who wondered how she could isolate from her small son, which is clearly unnecessary, something like that, and that would be unduly alarming. But for someone who's older, who has other risk factors, who is on immune suppression, then clearly they do fall more into the high risk category that should be looking at self-isolation or whatever. Sue, do you want to make a point with that?
Yes, I just wanted to add about splenectomy, that it is not so much a increasing susceptibility to viral infections, but once a viral infection takes hold, then secondary bacterial infections can exacerbate, make the problem worse. And so splenectomy puts people more at risk of a bacterial infection, and that's why we are prompting people to be more vigilant with their prophylactic antibiotics than you might previously have been in recent years.
Yeah, that's a very good point. Yeah, thanks for reaffirming that. The issue of isolation and what you do with yourself. Now, Rhonda, how have you coped with this? Are you being devil may care and not worrying, or what are you doing?
No, I think that we're being very careful.
Good.
I was very interested to hear Sue's point there about the splenectomy, because I had a splenectomy in 2000, and I haven't taken any prophylactic antibiotics for quite some time. I did take them, I think, for about 10 years. But now, you think I should go back onto them, ask my GP for them?
Or do you think you should just have a supply?
Yeah, I was going to say that exactly, Adrian. I think just ask your GP for a supply so that you can be on the front foot. So if you start to develop symptoms of COVID or a virus, then you can start your prophylactic antibiotics to prevent that secondary bacterial infection.
Yes, I think I've got coamoxiclave or something like that. Thank you. I think that generally speaking, I think really you have to, get the knowledge, which is what people are doing right now on this webinar. But I think that you do actually have to have a balance and weigh up your own risks with all the knowledge that you can gather. And I think there's plenty of that around, and of course, specifically today for ITP. We're not going out, meeting friends, doing anything like that socially. We are actually going for a walk every day we're very fortunate. We live near Woodford Green, and we've got the forest and we've got the golf course. So we go out for about an hour, and, you just avoid people basically. So I think that's very low risk. And, at home, we're being careful, washing hands and all that sort of thing. Like a lot of people, we haven't been able to get any delivery of food. So in actual fact, my husband's doing that, going into the shops. But, that's the most dangerous thing we do, really. But I think that people have to be very careful that they don't get to the stage that they're so anxious. And I think also we are obviously all very aware of our own health condition and, the problems that might cause us. But I think for mental health, we also have to realise that our families and, you know, mothers and fathers, partners, children are probably all pretty worried about us as well. So I think that, you know, it is important to find out the facts and to be able to reassure them and to not get too panic stricken, I think, really.
Yes, I think those are important points. I think all of us of a certain age are probably being pestered by grown-up children. So that's some very useful points here, and we've had quite a few questions. Obviously, some of which the answers are speculation about the problems of the virus to patients with ITP, and as you've heard, there are very few patients with ITP who've been shown to have the COVID virus. Whether that suggests that some of the treatment protects them, I think some people have speculated that, but we really don't know, and there aren't enough. Of course, at least half of the patients that I'm aware of, the very small number, haven't had any serious disease at all, have been treated as outpatient, haven't needed to be admitted, and it's often the association with other risk factors that actually causes the problems. Age, diabetes, blood pressure, heart disease, that sort of issue, in addition to if you happen to be taking other immune suppression. There have been questions about what would happen. Is a low platelet count itself a risk for the virus? And I think we can say quite clearly that a low platelet count itself won't cause an increased risk for the infection. And I think there is some confusion because the platelet count has been known to drop. Certainly one of the questions came with the paper from China showing that a low platelet count was associated with a poor prognosis. Well, we know and have known for a long time that a viral infection drops your platelet count, and COVID is no different from that. And that's a reflection of the severity of the disease, and perhaps even damage to the bone marrow. And I think that's important. So there is that risk of bleeding. There is the risk of obviously of secondary sepsis as well, which Sue has highlighted. There's also a potential risk, surprisingly, of thrombosis, and about 30% have that. And I wonder if either Sue or Quentin would like to comment on the possibility of thrombosis and the implications of that in a patient with a lowish platelet count, or even a ITP with a reasonable platelet count who may get it. Should we be taking that into account?
Shall I start, Quentin? Yeah. Well, there's two sort of types of thrombosis that are discussed in the context of hospitalized patients with COVID-19. One is when there is lung damage to the alveoli, the small pockets in the lungs. That, as part of that inflammation and damage, there will be some thrombosis in the tiny vessels around those lung pockets, around the alveoli. So that's one type of thrombosis. And the other type is a deep vein thrombosis and a pulmonary embolism, which is in the large vessels in the leg, and then potentially going to the lung. And this is what all patients who are hospitalized are at risk of. And it's unknown at the moment whether COVID-19 patients are more at risk of that kind of thrombosis or not. But for every patient who is hospitalized, we will be assessing whether they should have prevention anticoagulation so that they don't develop a deep vein thrombosis and a pulmonary embolism. Now, in somebody with ITP, we would therefore be very carefully balancing their bleeding risk, if their platelet count is low, compared to the clotting risk of COVID-19. And that's partly also what we've tried to address within this document for clinicians.
Thank you. Sorry, I was just reading a question. Someone has just come up with an answer, which you may be able to see, Rhonda, and it's worth saying that some of the bigger companies like Asda, if you're a high risk, will actually organise an early delivery for you. I know someone was telling me yesterday they went onto a site of one of our big supermarkets and were offered a delivery in July, by which time you've probably starved. But you can as either an older person or a high risk person get on and do that. I know I went on to Majestic Wines as an elderly person, and they did a delivery within 2 days for me, which is worth knowing. Let's talk a little bit about the risks and work. We've had quite a number of questions here, quite a number from people in healthcare profession, also someone who works within the police force as well. And of course, these are all people who meet potentially high-risk patients. And Sue mentioned the question from someone who worked in a critical care setting, just an old Tomapac, hadn't been on steroids for some while, didn't say if they'd had their spleen out, but in the critical care setting, you're still likely to be prone to getting a very high viral load. And that does seem to me a risk for someone who's had immune suppression in the past. And I think it's anyone who's been on immune suppression in the past. And if it's been rituximab over 12 months or more away, then I don't think that's an issue. But I think there is that problem of being maybe more prone if you're taking some of those tablets, particularly in a healthcare setting. And I think some of the hospitals with very high instances of COVID and high numbers of deaths, I think would be, again, somewhere where you would have to be particularly careful for. Drew, do you want to make any comments on that?
I was just thinking, patients sometimes ask me, and I don't know whether you've had this amongst the questions, about the concept that because you have ITP, you are somehow immunocompromised from just having ITP. You know, my immune system's weak or not normal. And the thing is that ITP patients are normal people. They just have an antibody or another cell which is doing some damage, but the rest of their immune system is pretty good. It's normal, effectively, unless we render them abnormal by giving immune suppression. But ITP on its own, I think, is not an immune suppressed state, but some patients seem to worry that they might be, but they're not. I think in terms of guidance from the scenarios that you gave, of course, the healthcare workers are at very high risk. Those in intensive care are at the highest risk. Those with immunosuppressive therapies should obviously avoid these kind of risk situations. If you are a healthcare worker and you've had no therapy for a year, or you've never had treatment, then of course you're effectively the same as the rest of us. But again, all precautions must be taken because it's a high risk scenario, whoever you are. It's very difficult to draw sort of didactic kind of distinctions, but it's a scary time for those without ITP. So those with ITP are a particular risk if they are suppressed, and they should certainly be removed from that setting. Obviously, maybe not the hospital, but certainly, as you say, intensive care, the viral loads in the air and from the patients is very, very high. So the risk is at the highest, obviously, intensive care. So if there's any worry at all with a patient in terms of prior or current therapies, I would ask to be removed from that setting.
Mm-hmm. And I think the question from the person who worked in the police as well, I think that they've obviously, their employers have actually made quite a significant number of adjustments. So they don't use the kitchen, they have their own toilet, they have an office to themselves, they're not meeting patients, they're not meeting the public front line. And I think those sort of things, that's the risk assessment, that's fine. The patient is on a low dose of immune suppression and needs to be careful, but I think certainly in healthcare, you've got to take that into account. And I'll just maybe reiterate the point you made about in ITP, you actually do have a normal immune system, apart from the fact you've developed an autoimmune disease. Because someone certainly said, I understand that ITP does not allow you to develop antibodies, which is certainly not the case. We wouldn't immunize for splenectomy if it didn't work. We wouldn't be suggesting the flu jab once a year if it didn't work. So it's very important to do that. There was also a question about herd immunity and the impact, and what does that mean? And in general, for things like measles that are highly contagious, herd immunity is probably about 90, has to be about 90% to protect the general population. We don't know with COVID-19. In some diseases, herd immunity is as low as 40 to 60%, but that's conceivably a very long way off where we are now. And I think the issue of vaccines has come up on a number of occasions. Now, I suspect we don't have vaccine experts here, but if anyone has any thoughts about it, then come in. But certainly, I don't imagine a vaccine is going to be available much before this time next year, and it's not something that we need to rely on. I think good antigen testing, look and see if you've got the disease, and eventually an antibody test if you have it. That's certainly not available with those at the moment, but I think that's what we will want within the next 3 to 4 months.
The vaccine point is a very good one, Adrian. We're assuming that a vaccine will be possible. It may not be possible at all, ever. Where's the where's the common cold vaccine? Where's the HIV vaccine? It's a virus, but if we wait for a vaccine, we may have a very long wait. So we have to deal with other ways by testing and contact tracing and things like that. Don't rely on a vaccine which may never materialize.
I mean, that's an important point, because I mean, how long have we known about HIV and we're still
exactly.
Can I just reiterate a point that Adrian said earlier, just to make it really clear so that people aren't anxious. But people may have read or heard that low platelets have been linked to poor outcomes in COVID-19. And I just wanted to re-emphasize what Adrian said, that it's not the low platelets that cause the patient's decline. This end stage drop in platelets is not related to ITP. It's a marker that the COVID-19 disease is very bad. Doesn't mean that if you have a low platelet count because of your ITP, you're going to have a poor outcome. It's a different pathology.
I think you're right. I'm sorry, I was just going to agree with Sue. I think if you look at the old papers from intensive care and the people where they base it on platelet count, those with a low platelet count do much worse in intensive care, no matter what the cause for being in intensive care, whether it's a road traffic accident or infection or post-surgery or something. The platelets being low is a very bad marker of outcome. It's because of the drugs they're having and lots of other factors. So it's not specifically COVID-19 and the profound low platelet count, is intensive care and all the things we do to them and the underlying disorder, disease, pathology, whatever you want to call it, as well as complex.
And I hope the participants are really taking that point on board, that we don't want to minimize the problems people have with ITP, but we want to say that the ITP itself doesn't make them more prone to infection. Some of the treatments that we give them may make them more prone, and it's possible that some of the treatments may impact on the course of the disease. We just don't know that at the moment, but there's a lot of information being gained out there very quickly, and a lot of the advice is currently best guess. Now, again, something that worries me, and I'd maybe like Rhonda to comment on, it worries me particularly with some of the poor advice about shielding and isolation as opposed to distancing, the impact this has on patients' mood. You know, I think patients could get very depressed. It could affect their mental health if they're sitting there. I know you've written in the platelet recently a very nice article relating to your work as mentorship and support there, and I wonder if you'd like to comment on that, Rhonda.
Yes, I think that it is a very serious health issue, and I mean, I'm pleased to see that it is being talked about in the media and being recognised. As I said earlier, I think that, you know, you do have to, perhaps with your medical team, if you're not really able to assess it yourself, is to assess your own risk and to be realistic about it, and therefore do the things that you know, you want to do. For instance, we want to go out for a walk every day, and I don't really feel, doctors may be able to enlighten me on this, I don't really feel that I am at high risk to go out for a walk, or even medium risk. because I think it's really important to get out in the green space for your mental health and for the exercise. And, you know, sometimes I do see my friends, which is quite nice. We stay a long way away from each other and have a very short chat, and it is quite good to see people, but obviously you wouldn't go socializing with them in an unnecessary manner. So yes, I think that you have to be very careful when you're at home to look after your mental health and to be doing things at home that are going to help you to alleviate your worry. I mean, I have to say that, you know, my husband is very worried about me getting it, because I do have a couple of other underlying conditions as well. So, you know, I don't feel too worried about it. I think he's not as worried as he was, but I think that you can get very, very anxious, and it's important to find ways to alleviate that. And I think one of the best ways to do that is to have a project, some kind of project to do that you can interest yourself in. It might be your garden or reading or looking up something you've wanted to do for a long time and never got round to. But I think that's really good for your mental health, and it does take your mind off your worries. And also during the day, instead of, you know, sort of sitting about concerned about everything, I try and have a little timetable for myself to do the things I really want to do. And, you know, I don't know what the doctors feel about that, but I think that it is important to do that for yourself when you are isolating a lot, and still keeping in touch at a distance with email and phone calls and that sort of thing with friends.
And try not to watch the news. Try not to watch the news too much.
I think that is true, that you don't want to be overburdened with the news, but I do always watch the government briefing every day. And I have to say, because I don't like doing one thing at a time, I do sit down on the floor and I do my stretching exercises while that's on.
That's a good thing to do when you're listening to the government comments. I think your point about exercise and walking is a very important one, and I have to say personally, I see no problem in going out for a walk if you've got somewhere where you can walk, where you're not mixing with other people. I've been surprised when I go for my perambulate, how if people see you coming on the path, they separate. We're fortunate to have a park close by that isn't very busy, and people keep to themselves. There aren't groups congregating, and I think getting out in the fresh air, and we're quite lucky at the moment because the weather's quite good, but getting out there is really very important, and having some sort of structure to your day with things that you want to do, rather than think, well, what am I going to do today? I don't know. And I think that's really the difficult point. Another question I'd like to ask is, actually, people are unwell. They sometimes need looking after. They sometimes need reviewing. What do you say to your patients, Quinton, Sue, Drew, about coming to the hospital for blood tests?
Well, we try and keep blood tests to a minimum, and so if people are chronic and stable, we may just roll the appointment forward 2 or 3 months if that's possible and they feel well. If blood tests are required, our hospital has set up a safe drive-through blood test arrangement in one of the big car parks. I imagine that's similar to in Quentin and Drew. Is that the same in your hospitals? Trying to manage the blood tests that are necessary, and just keeping everyone distant.
Yeah, I mean, for us, we can often encourage individuals to have blood tests at the GP, so we'll post out forms and they do it in the community. Phlebotomy in the hospital, you don't need an appointment, so you can attend, have the blood test and go. But there are not specific drive-through this time. I think that, yeah, we're all trying to be rational about the frequency of tests and attendance. All my outpatient clinics are clinics. There's nobody coming to our outpatients at the moment. But if you are on an immunoregulatory, immunosuppressive treatment or a TPRA, an occasional blood test does remain necessary in order to safely prescribe. So while we're trying to increase the interval between tests, there are time points where you do need a blood test.
Yeah, we're similar. We're very similar. The only slight worry is, and I think, Sue, it's in the document, if someone starts on a thrombopoietin receptor agonist, you have to then do some monitoring fairly regularly initially, and that's already in the document. That's the only time I think we run into problems, the main time we run into problems.
The specific question I'd just like to aim at Sue is the issue of pregnancy. I mean, I'm not aware of pregnancy and ITP and COVID being an issue at the moment, but there've clearly been a number of pregnant women with COVID, and we had this awful case yesterday in the press of the poor nurse who died. And we do see occasional patients with ITP, a steady stream of over the year, and as you know, there's now a pregnancy registry where we're trying to collect that data. Do you have any specific points you'd like to make about pregnancy and ITP?
Well, pregnancy is not thought to increase susceptibility to COVID infection, but if COVID infection does occur, pregnant women would struggle to deal with it more, particularly if they're heavily pregnant and unable to expand their lung bases very well. In the context of ITP and pregnancy, with or without COVID, we wouldn't alter the current management that we have for all patients with ITP and pregnancy. In general, we use a lower starting dose of steroids in pregnancy than we do out with pregnancy anyway, because we don't want to induce any diabetes or that pregnant women are susceptible to if they're on steroids, any high blood pressure or growth restriction of the baby. So we're more cautious with steroids anyway, and we do use the minimal dose for the minimal duration of time. We're a little bit more limited anyway with options for treatment of ITP in pregnancy because we don't want to cause any harm to the baby, and many of the drugs are off-label. So in the later stages of pregnancy, it may be okay to use a thrombopoietin receptor agonist. It is off-label, and it would be if steroids and intravenous immunoglobulin have not been successful.
I mean, that's certainly toward the end of pregnancy, isn't it, in the third trimester?
Just to the end, yeah, just at the end.
That's probably a good thing to do. Well, let's hope we don't face up to that as a problem. Yeah. Obviously, we're coming toward the end now, and I think we've covered quite a lot of the points. As I've said, we have a lot of questions that we haven't been able to cover them all in each one in detail, but I hope I've covered most of the points that have come up within the questions. I think there's several take-home messages that are important to come out of with here. One is that ITP itself, the low platelet count, doesn't make you prone to the coronavirus. That obviously some of the treatments may well do, as I've said, and in the patient, and of course the average patient with ITP is the male over 60 who may well have comorbidity. That if you have a comorbidity, then that has to be taken seriously, particularly if you're on some form of treatment as well, because those are potentially additive. But I think the point that Sue made very strongly is that the low platelet count per se is not an indicator of the severity of the disease. A low platelet count falling with a COVID infection is the end result of a lot of things going on, is something we've always recognized in very ill patients in an ITU anyway, and COVID-19 are no different from that. I think while we are currently searching for what's going on, the government's advice on social distancing, on isolation, and on shielding are important to follow, but it's important to be pragmatic about that. And someone who's had a splenectomy 12 years ago, who's on steroids, who's on penicillin, who's had no other treatments for many years, has no significant increased risks, and you shouldn't be disrupting your life and that of your family purely on that basis. And again, to the person who said, why isn't there clear advice? Well, it's difficult to know where the central point of advice is, but certainly in the UK, the British Society of Haematology has that on its website. The ITP Support Association has advice for patients on its website, and we also put on the document that Sue's pulling together. Although for medics, I know that a lot of you read this avidly, and I think maybe a point I would quite like to finish with is that what we're trying to do with these seminars, with the data we're putting out, is actually to develop the expert patient. The average GP in the UK will probably see 1, 2, 3 patients with ITP in their lifetime. Even the district haematologist may only see 1 a year. So they're looking after so many other things, and particularly at the moment, they won't have these specific things at their fingertips. So it's important that patients are aware of that, know where to go, have that information. Most doctors have no problems with a patient coming along with some clear understanding of what the issues are, and asking intelligent questions. And most GPs and most doctors will actually want to pursue and find out more about it. So I think I would just like to make those points. And I think certainly people in employment look very carefully at what you're doing and who you're being exposed to. But in particular, in health, anyone in healthcare, and particularly some aspects of healthcare, are very exposed to risk. And many hospitals at the moment are, I hate to use the term war zones, but are really very difficult like that. And you need to think very seriously about whether you fall into that at-risk category. Would any of the other panelists like to make any specific points? We have a few minutes. If you'd like to add anything you think I ought to reiterate and shouldn't.
I think yeah, sorry. Sue, Carrie, I was just going to congratulate Sue, in fact, on her document, her guidance, because this is a very fast-moving area. We're learning day by day. This is new data that we're all accumulating. So there's no sort of off-the-shelf guidance, because we've never faced this kind of thing before. And I think Sue did very well to get this information together, which I hope the patients can read and other clinicians will read as well. Sorry, over to you, Sue. Sorry to interrupt.
No, thank you very much, Drew. All I was going to say is that, I hope this has provided some reassurance for patients with ITP, because we are very understanding that this is a anxious time for you. And you know that COVID is associated with hyperimmunity, and that's one of the problems. And with immune thrombocytopenia in the label of your condition, that makes you more anxious. But all I could say is, if we haven't answered your questions, then please do talk to your doctors, because they're right behind you, and they want to make sure that you have the best care and best support.
Quentin, do you want to make any points?
No, I don't think so. I think you highlight important things, and I hope that's been reassuring, actually.
Okay. And so I think we ought to finish off with a patient's comment. So Rhonda, would you like to make any points to wrap up?
Well, I think, today I hope that people who have asked questions and who've been listening in do feel reassured. And I think that this kind of thing is really what it's all about, isn't it? Is reassuring people and helping them to understand their condition better and how to manage it, and to be a good self-manager of your condition. And I think really that's what it's all about at the moment, because people are not being able to go to hospital. I mean, one of the things I wanted to ask the doctors is if in their hospitals they are doing any kind of Skype or telephone consultations, instead of when a patient is supposed to be turning up for their outpatient appointment, if they're going to be able to have some kind of consultation that way. I know it's difficult if you actually need to examine a patient, but if you don't, is that an alternative that you're using?
Yeah, I hope for for us 100% teleclinics.
Yeah.
Yes,
Many,
yes.
many going that way now, I think. And it'll actually be very interesting after lockdown to see how many persist. I know
Yeah.
in some conditions, patients like the face-to-face interaction, and but there are quite a number of patients who you deal with where it will be very easy. The patient has a blood test at their convenience, and then you either Skype or whatever them and just discuss the implications of that. I think that could save everyone a lot of time, and we would have probably developed it years ago if reimbursement for those teleconsultations had been changed. So yeah, I think we'll see what comes out of this. I would hope that we'll learn lessons that will be taken on board, and let's hope that certainly in the UK, the degree of testing comes through quickly enough for us to be able to do what has happened in other countries, which is there's rapid diagnostics, contact tracing, isolation, that then allows us to move on. And I think that's the way forward. And ultimately, maybe antibody tests that tell people if they've got it. So hopefully, if that does mean immunity, which it may well, the virus itself doesn't seem to mutate much. So quite possibly, antibodies will provide several months of reasonable quality immunity, which would then maybe kick in again if the infection happens. I think it's also worth pointing out that, of course, coronavirus causing chest infections isn't new. COVID-19 is new, but there are a small number of infections out there, and one often wonders if some of the sporadic infections that have been picked up were in fact the coronavirus that we know is in the community anyway, that has low infectivity and low prevalence. We just don't know that because we don't have a test for it, but it's an interesting speculation. And I think there are many speculations. I made the point earlier, rather flippantly, that maybe ITP protects you from the infection. And someone did ask about the cytokine storm and ITP, and we have speculated whether the anti-inflammatory treatment damps that down. I think we just don't know that, and I wouldn't like to take the risk at this stage. But I think there are a whole lot of things like that that will come to the fore and will be chewed over no end over the next few months. So I think on that note, I'd like to thank the panel for an hour that's really gone extremely quickly. I think we've answered a lot of the questions that have come up, both I received before and I've seen coming up on the panel. Now, there are one or two specific points we haven't been able to deal with properly, but as I said, for members of the association, if they email Mervyn with specific points, then we can try and answer them. So I'd thank everyone on the panel for giving up their time this afternoon, and for the participants, maybe hand over to Mervyn just to wrap things up.
Okay, thank you very much, Adrian. And you know, from the perspective of us at the headquarters of the ITP Support Association, thank you to all the panel. It's been very interesting, you know, listening to all the comments, and I know, you know, the vast number of questions that we actually had in prior to this and actually during this hour as well. I do believe we've answered the bulk of them because they were all grouped into different things, but, you know, many thanks. As I've already said, this webinar is being recorded, and I will make it available on the website as quickly as I possibly can. But just for people out there, if you're not already a member of the association, you can join by visiting our website, where you'll find lots of useful information and lots of resources to support you through your ITP journey. In addition, we are updating our COVID-19 page all the time. As Adrian said, like, you know, there's guidance coming out all the time. We're adding various links to all the government's websites and other useful websites around the world. You will find them on the COVID-19 page at itpsupport.org.uk. Other websites that we would also recommend is the Global ITP International Alliance, which I mentioned in my introduction. That is globalITP.org. They have some fantastic ITP and COVID-19 resources on there. In addition, you can also find some other excellent resources at the PDSA.org. That is a sister organisation in the USA. Plus, there's also useful information at the UKITPforum.org. This is a website that covers all the ITP specialist centres around the UK, and a website that I know Drew is very, very much behind is the UKITPregistry.com as well. And finally, one other website, the British Society for Haematology, which is b-s-h.org.uk, and they also have a very, very useful page on there covering COVID-19 for ITP and other blood disorders. Finally, please remember, we will get through this pandemic, hopefully in the next few months, and thinking with that positive vibe in mind, I'd just like to look ahead to better times. Many of you will already know that we've moved the date of our 25th anniversary convention in London, which is being held in the centre of London at the Royal College of Pathologists, from the original date, which was due in May, and we've moved it now to October. Likewise, we've also moved our Ireland ITP Patient Day, which this year is being held in Cork, and we've moved that from June to November. So there's a few dates for your diaries there. So once again, a huge thank you to everyone watching this online. And I'm just looking at the Facebook numbers and all now, they are excellent. So thank you to all the panelists, all the sponsors for making this event possible. We will, if needed, be having more of this in the weeks and months ahead. We're also planning to have many, many more of our local group meetings online as well, but having future webinars is also in our planning stages. So from me, stay home, stay well, and stay safe. Thank you very much.
Thank you very much, everybody. Thank you.
Thank you.
Thanks.
Bye.
Bye.
Goodbye.
Thank you.
Thank you. Bye-bye.
Bye.